All right. Uh, all right. Good evening, everyone. Thank you very much for coming through for our AFRAN webinar for today, hosted by the clinical nephrology team. We will be having a talk by Dr. Elliot Tanner. He will be giving us his view on how to convince our health minister to invest in CKD prevention. But before he goes ahead with his topic, I'm just going to quickly introduce the speaker to everyone. So Dr. Tanner is a senior lecturer in the Department of Medicine, School of Medicine and Dentistry at Kwame Nkrumah University of Science and Technology. And he's also a senior specialist physician and consultant at the Komfo Akonye Teaching Hospital in Kumasi, Ghana. He's a fellow of the West African College of Physicians and a fellow of the International Society of Nephrology after training in Cape Town in 2016. He's an educational committee chairman of the Ghana Kidney Association and the chairman of the Young Nephrologists Committee of the African Association of Nephrology. He's a member of AFRAN's COVID-19 working group and a member of ISN DOPS COVID-19 survey group. He's a member of the ISN Educational Committee and part of the first cohort of the Emerging Leaders Program of the International Society of Nephrology. He's a Senior Atlantic Fellow for Health Equity with George Washington University, championing the health equity and access and management of kidney disease in Ghana. He is the founder and the CEO of Kidney Health International, a local NGO promoting kidney health in Ghana and beyond. He has 23 research publications written 17 educational online publications on kidney disease prevention. He's a kidney health advocate, health promoter, and educates the general public about kidney disease and its prevention. He has organized free kidney health screening for over 3,000 people, set up renal management teams in 5 district hospitals in Ghana, visited 13 radio stations, 9 television stations, 23 organized groups educating on kidney disease prevention in the past 4 years. He has written a book on how to prevent kidney disease, which has been launched in 2 regions in Ghana. Dr. Tanner is a principal investigator at KNUST site of H3 Africa Kidney Disease Research Network. This big multinational African study has recruited over 7,000 subjects with chronic kidney disease and controls. This study will allow understanding the contribution of APOL1 gene variants to the development of chronic kidney disease in Black Africans. He's married with 4 children and learning how to play piano. So it gives me great pleasure to invite Dr. Tanner to give his talk on this important topic. Dr. Tanner, the floor is yours. Thank you.
All right, so thank you very much, Maza, for that introduction, and thank you so much. Indeed, I'm the past chair of the Young Nephrologist Committee. I think that correction should clearly be made, and it's such a pleasure to be invited to discuss what I think is a discussion on how we can all convince our health minister or people in the health affairs in our various countries. And this topic was actually an invitation by, as you can see, it's the slides I used for the just ended WCN in India. And for me, it was fascinating that I was invited to do this talk on such a huge platform. And I kept asking myself, oh, okay, so probably WCN or ISN things have been able to convince my health minister enough to be able to share what I have with the global world. Unfortunately, most of us, I believe, who might need the talk could probably not make it to India. So when I was invited, I thought, listen, why don't I, bring the discussion for us to have and pick a few tidbits on how best we can convince. And indeed, you cannot, as a nephrologist in a part of the world, work in silos. You actually need the minister, you need, the people who are major stakeholders in health, or otherwise you just get tired virtually. So that is what this topic, and I'm hoping we'll be able to engage. Please, I don't have all the answers, and be happy to also share what you know when we get to the question time, so we can actually move ourselves forward as Africans. Okay. So I have no potential conflict of interest to share. And indeed, my objectives for the next 40 or so minutes is to have a discussion on how you can make kidney disease a priority. To be honest with you, if you start engaging people just know that they don't care much about kidney disease as you do. And that is very important for you to realize. So you may need to let them understand where you are coming from, what you see all the time, so they can appreciate you when you talk about kidney disease. And then how you can generate the appropriate data locally. If you don't have it, you can always rely on other data to be able to help make a case in terms of the priority. And you need to work to that minister of yours, letting them know what the benefits are economically or health-wise for CKD prevention, or else you will not be able to make your case. And why it is important to realize that, yes, you might think of yourself as a nephrologist or maybe a nephrology nurse or somebody in the nephrology fraternity, but you need what I call other constituents to be able to help with your advocacy, and you work with all the constituents you can work with. And then I'll share some gains we have made here in Ghana, which is a low middle income country here in Africa. All right. So in making chronic kidney disease a priority, you need to let them understand what the statistics are globally. So I think this is common knowledge for all of us here that about 10% of the population, one way or the other, globally, have some form of chronic kidney disease. And you need to drum home this point to your minister. And then you need to let them know that millions will die each year because of lack of access. And I think for us, it's very easy to make that point because we know from various countries across Africa that most of our patients, especially Sub-Saharan Africa, will end up getting kidney disease, and indeed they will die because they cannot access treatment. And unfortunately, it leads to poor quality of life, and it increases the risk of other cardiovascular diseases. Your average patient who gets kidney disease might end up dying from cardiovascular events even before they require dialysis. And that is a major cause of premature mortality. And it is important to realize that the statistics will even get worse if you and I don't do anything about it. And for that matter, the minister does not do anything about it, where we believe that in terms of 2013, chronic kidney disease was ranked about the 19th most common cause of death. But if we don't do anything about it, then by 2040, it will be ranked as the 5th most common cause of death. And this is the reason why we have to hit the ground running to be able to convince our minister on how to improve kidney disease in terms of ensuring that we target prevention, because it is always cheaper. Now, despite the growing burden of chronic kidney disease globally, it is still underdiagnosed, and that is why we need to pick it up early. So data shows that about 60% of patients with CKD are undiagnosed, and indeed, this is actually the developed world, one way or the other. That's where this data is. So if we look at our data here in Africa, it might even be worse. Now, the stages of CKD, which are the early stages up to stage 3, where you and I can do a lot about to ensure people don't progress to kidney failure, over 85% are still undiagnosed, and they are out there. Like we started having discussion even before the webinar started, a lot of our patients will crash land, and this will not change until we begin to look at how best we can prevent kidney disease at the early stages. So if you are seeing you're diabetic or you're hypertensive, we need to maximize picking up at the early stage to ensure they don't get into kidney failure. Now, the whole spectrum of kidney disease starts from a risk factor all the way to day developing end-stage kidney disease. Unfortunately, where you and I can do a lot about is picking them at the level of the risk factor, where we can prevent at all they're developing chronic kidney disease. So you picking your diabetic or your hypertensive. And then again, if you pick them up in an early stage, then we are slowing down their progression so they don't develop complications. That is why we need to be targeting. Unfortunately, the large majority of our patients will come in very early, they are crash landing, and sometimes it's conservative therapy. And it is indeed important you realize that our conversation in Africa should not be about dialysis, hemodialysis, peritoneal dialysis, and transplantation, but our focus in Africa should be in prevention and, of course, slowing down progression and then preventing complications. But unfortunately, when in Ghana, for instance, we're celebrating our 50 years of hemodialysis, and as per the data that we have, in terms of what we know, only 8% of the people who will require dialysis or require renal replacement are actually the ones on renal replacement. The question is, should we wait for them to get here, for a few of them to get on renal replacement, or can we target them early enough so they don't get to require renal replacement therapy? What is it like in terms of numbers when we compare ourselves to the global numbers? So this is the ISN Global Kidney Health Atlas, where I try to combine the data of 2017 to 2023. Where in looking at it, like I said, if we don't do anything about our kidney disease, then the majority of them are going to require renal replacement therapy. Now, if you look at the blue, those who are indeed receiving it. And then if you look at is it the orange or the yellow, they are those who actually need it. And obviously, those who are needing it are more than those who eventually get it. And it's even worse when you look at low income countries and low middle income countries, of which majority of the countries in Africa or sub-Saharan Africa fall in, where it's about 6 and 2 and then what 6%. And indeed in Ghana, like I've shown you, it's about 8% will end up getting it when they require renal replacement therapy. And these numbers are so worrying and devastating that we cannot sit and wait for people to get there, but we need to target prevention and early detection, or else it leads to increased morbidity and then mortalities. Now, I have always loved this slide, which was first shared by Valerie. And Valerie actually presented such a wonderful paper. And I actually asked her for this particular picture because it's such an important picture for me, because that is how I saw myself as a nephrologist here in Ghana, where it looks like I'm spending all my time, pulling people out of the drowning river. Now, the point is that as a nephrologist, and I believe that wherever you practice, you probably feel the same, that how on earth can we keep pulling them out when we can find out how they are getting there in the first place? So my question is, why are there so many people falling in the river in the first place? Because obviously we don't have any clear prevention and early screening programs in our part of the world. And it's indeed important that we look out for these people to ensure that they don't fall in the river in the first place for you and I to keep dragging them out of the river. And indeed, it is tiring. So we need to ensure that there are prevention and screening programs in our countries. And we cannot do this alone. As nephrologists, we need to get our ministers and our stakeholders involved. Now you need to make a case with all the relevant data that you can get. But I think you can say that, okay, listen, I may not have the data that I need, but you can always, bank on some data that is available. The global burden of kidney disease data is available. The ISN, like I've always already started sharing, ISN Global Kidney Health Atlas also has valuable data that you can work on, because they actually got data from various countries, and indeed Africa also shared some of its data. You can also look at data from other renal societies, or there's a UK renal registry, but ISN also has valuable data in terms of the ISN toolkit to ensure the share RR data is available in your own country. But nonetheless, our AFRAN registry is also there, and I would encourage all of us to be able to get some information from Prof. David, who happens to be my mentor in my training in South Africa, and to ensure that we are getting the right data that we can use to be able to make a case from our various countries. But nonetheless, it is always important that whatever you have, be it a hospital data, community data, rally that data to be able to ensure that you are speaking fact to your minister when you meet the minister. Now, I am just sharing with you some data that we collected in my teaching hospital, the Komfanochi Teaching Hospital. It was not a high-end data, but it was useful with all my engagement that I had with my regional health representatives, or my minister, so to speak, because at least you can speak to a local data. What is this data? It was just a hospital data we collected over 10 years, and it is something simple that you can collect. What did we realize? That over 71 patients were reporting with end stages. And indeed, as simple as it was so emphatic. And when you meet these people who make the decisions, that listen, why are we not seeing them early? And we can actually ask questions to be able to help these people. It's by virtue of this same 10-year data that we're able to realize that our outpatient numbers in terms of people coming with kidney disease had virtually quadrupled. Those who were coming with kidney disease on admission had tripled. And unfortunately, about 30 to 50% of our patients will die on admission. That is not to talk about those we send home to say, come back in 2 months' time, come back in a month's time, who don't come because, of course, they die out there. This is data that we actually wrote death certificate for with kidney disease. And that was really telling when I put this data together. So you don't need, high-end randomized control trial, whatever it is. Hospital data sometimes can speak to these ministers, for which after this data, we're clear in our mind that we don't have time. We cannot watch these 30 to 50 people die always on admission. We need to run with this data. We need to move as quickly as possible to ensure that our patients don't come dying from kidney disease. Now, it is good to get data, but trust me, it is also good to hear patients speak. So it is always important, like we say, that stories are powerful tools. When patients are able to speak their story or tell their story the way it is, we'll be able to make more gains. So the image you see on my slide is actually myself in a television station here in Ghana. I think this was in 2018, where the lady sitting on my right, on the left on the screen, actually happens to be a patient who is a journalist who had kidney disease and was actually on dialysis. And she was ready to come share her story, which was also powerful because she had the power. She would share her lived experience, and people watch it and they can relate more to her than even all the data of the percentages that you would want to share in your reportage. So it is very important that we realize that if we have people like that, they can help us to make a strong case with our policymakers. So partners with kidney disease who are ready to share their story, it's difficult to identify them because a lot of patients who don't want to share their story. It's true, but you might find one or two who are willing to share their story, show their faces, and trust me, they are powerful tools to use. Why? Because data speaks to the head. So all your data, 15%, 10%, and all of that is speaking to people's head. But stories, like they say, speaks to people's hearts. Why? Because it changes perception, it influences public policy, and I'm going to share more with you as we get along, and it helps to build coalitions, because sometimes as nephrologists or nephrology nurses or surgeons, we think that what we see are the ones that speak the story. No, we need to get patients involved and patients groups involved because they are powerful tools. Now, can we make a case for early screening of kidney disease? Yes, we can, because the Wilson and the Jagna principle of screening are such that when you are able to get a patient who get a condition that satisfies all of these, we will be able to say that, listen, if we screen people, we are not just leaving them to rot, but we are leaving them with some options in terms of how to diagnose, or how early, if you diagnose them, they have some options in terms of treatment. Now, I'll try and go through these principles. There are about 10 of them. And then you realize that chronic kidney disease virtually satisfies all of these conditions. One, is chronic kidney disease a disease that has an important health, qualifies as an important health problem? The answer is yes. Does it have a natural history that indeed, when you're able to pick it in terms of development of a latent stage, when it's declared a disease, is it clearly understood? Yes. You and I know when you have a diabetic or you have a hypertensive and you pick them up early with even protein, even before the renal functions go off, you can follow them and ensure that they don't develop kidney failure. It is clearly understood. Is there a recognizable latent or early symptomatic stage? Yes. And indeed, in our own, even the early stages are largely what? Asymptomatic. And that is why you need to screen, because you can pick them early and prevent them from progression. Is there a suitable test? Of course, a urine test, renal function test can be done. Is it acceptable to test the population? Obviously, all you need is a simple blood and urine test, sometimes blood pressure measurement, and boom, we are there. Should there be an agreed policy on who to treat? Clearly, we have who to treat and who not to treat. Is there protein? Is there early enough? Are the patients diagnosed early enough? Do we have medications that can be used when they are diagnosed? Obviously, yes. We have our ACE inhibitors, and now we have newer medications that we can use to prevent progression. So yes, it does qualify. Are there acceptable treatments? Yes, I've mentioned that already. Are there facilities that can diagnose and treat them? Yes, virtually every facility should be able to do a urine dipstick. You do a UACR probably in a high-level facility and do a renal function test. So you realize that is that the case finding actually economical as compared to the expenditure of treatment? Of course, chronic kidney disease sits largely in there, where indeed, if you're able to pick it with simple tests, you can actually prevent catastrophic health expenditure with its care. And then, of course, the case finding should be a continuing process, not a once and all. So you and I, in most cases, will do a World Kidney Day screening, and then we leave our patients to rot. But now we are saying that if you pick it up, it should not be a once-off project. It's something that you need to follow up the patient looking forward to ensure that they don't deteriorate. And these are some of the things you and I should be very particular about as nephrologists. And you realize that chronic kidney disease virtually satisfies all of these conditions. So we can screen people early and we can prevent them from progressing or getting kidney disease even in the first place. Now, who should we screen? Now, KDIGO's recommendations are that we should screen high-risk people. Now, as per the strategy, populations with common risk factors should be prioritized. So you can have people with diabetes, people with hypertension, cardiovascular diseases, and you can realize that things like obesity, race, like the Black race, older age, family history of kidney disease, people who are using nephrotoxins, genetic factors, people with prior acute kidney injury. Now, when I look at this slide as a nephrologist practicing in our part of the world, you can clearly see that virtually every patient you see, one way or the other, is at risk of kidney disease. So this high risk, like you can see the Black race, for instance, virtually if you are in the population where the majority of them are Black, virtually every one of them is at risk of kidney disease. Nephrotoxins, we have all our patients taking herbal medications, taking painkillers, and so on and so forth. So personally, as a nephrologist, almost every patient I see is at some risk of some sort to chronic kidney, at some risk to chronic kidney disease. So for me, the risk for the screening virtually should be across board, especially if you are above age 40. Let your minister understand the benefit of prevention of early prevention and early chronic kidney disease program. What can you say? If you pick them up early, we can slow the progression. If we pick them up early, we can improve cardiovascular outcomes. If we pick them up early, we can prevent those who are going on dialysis. So if the country is not paying for dialysis, then you are letting them understand that if you pick them up early, those who end up going on dialysis will reduce, and chances are that they may not need to spend as much as they are spending for those maybe on dialysis. If they've not started taking care of patients on dialysis, then you make a case to them that that individual might end up being picked up early, and then they can prevent themselves from developing kidney renal failure eventually. Now, the overall mortality also reduces, and it improves the eligibility for living donor transplantation. So we have all the reasons why we need to, because at the end of it all, it is actually going to save them money. And these are some of the things you need to let them understand. Now, you can show them this, that if we pick people up early, so now this slide, I love it so much because it tells you that even proteinuria alone, without intervention or with intervention, you can prevent people from developing kidney failure, right? Now, let's go through this. Now, the blue line up here is somebody with no proteinuria, with normal aging. Chances are that they will live to 70 years and above, and their eGFR will not drop to kidney failure like you have it. On the other hand, if you have somebody who develops proteinuria and does not do anything about it, then chances are that they might end up developing kidney failure maybe around age, let's say 40. And that is the average age by which people develop kidney failure here in Ghana, for instance, which I assume is similar to other parts of sub-Saharan Africa. Now, if you pick them up late, they might probably develop it, but they will develop it later in life. But the beauty of it is that if you pick them up early, then chances are that even if they will develop kidney failure, they will develop it later in life, which will be similar to those who didn't develop proteinuria at all. And this is actually very important for early screening, or a key take-home for early screening to ensure that people don't develop kidney failure even in the first place. You need to also make an economic case. Now, the minister would understand that it's all about money. So if you're able to make an economic case about money, chances are that they might listen to you. So now, what are the numbers? So this is data from the US renal data system that actually shows that they are spending about 90,000 per year for dialysis, okay, per person. But nonetheless, if you look at the KEEP program and all in terms of prevention, it might only cost us about 500. That is even pushing it to the limit. Dollars per year for prevention per patient. Now, if you put this to your minister, chances are that he would understand clearly that it's more cost effective to prevent people from getting kidney disease than to take care of people getting kidney disease. So that is a strong point. Now, the next point is the return on investment. Anybody who understands economics will realize that indeed health is not something that you are wasting the money, but it should be seen as what an investment. Now, what if you're able to take care of people, prevent them from getting kidney disease or getting kidney failure? These are the people who will be able to work hard to be able to ensure that what they are paying taxes to the economy. So the return on investment is good for the economy if you keep people out of dialysis, if you keep people from kidney failure. And that is how they should focus on the prevention, so they don't see it as wasting money to take, screen people, but which they're not going to get anything. But if they are able to screen people and prevent them from getting kidney failure, or screen people early and prevent them from getting kidney failure, these people will end up paying taxes back into the economy. The productivity is very important. Like we said, these are the people who are healthy and strong and will be able to work to pay taxes into the economy. If they are healthier, they are more productive to work. If they are not healthy, then they are sicker and they will spend more on them in terms of healthcare. So that is actually very important. The other point is that early detection works. You need to let the patient understand that early detection works. If we detect patients early, like diabetes or hypertension or people with a high risk of kidney disease, chances are that we pick them up early. They probably are still taking that painkiller. They probably are still taking that herbal medication. You pick them up, they stop it. Chances are that you can prevent them from getting into kidney failure. So definitely it works. And the population will be strong all the time to be productive. So these are some of the things. So don't be looking at it from the health perspective alone. You can also look at it from the what? Economic perspective. And our ministers understand this very, very well. Now, the hare and the tortoise. I mean, this paper we wrote when we're looking at the role of SGLT2s, which are new medications in terms of the upfront position paper. What I would want you to focus on is the fact that if you have a patient, for instance, for the Credence trial, who is about age 63, EGFR 56, chances are that if you put them on an ACE inhibitor ARB, you'll be able to give them about 10 years of their life before they get into end stage. Now, the beauty is that if they are able to get medication like an SGLT2, then chances are that you are giving them an extra 15 years. So if you put it together, you are adding some 25 years to a patient's life when you are able to pick them up early. And even this is when they have an eGFR of 56. So what if you pick them up early? Maybe you are giving them 30 years or 40 years. And that is what your minister is supposed to understand. Early detection always saves life, and it's always the best. Now, you need to strategize yourself that you are preparing for what the minister will say. Your minister will say that, if I prevent, how would I be able to account? Ministers in Africa are quick to, we built 3 dialysis centers. We put 10 beds in a particular hospital. They can quantify this. And that is why they can say that, okay, I did this. And their people are going to be happy with them that they built 5 hospitals. They did that. They need something that they can quantify. Now you are saying that they should do a screening program and prevent. How would they be able to come to people and say they have prevented this number of kidney disease? So indeed, it is a true fact, and you need to counter it when they come with that argument. 2, poor investment generally in health. We all know that the military is getting their funds, the agriculture is collecting money, security is collecting their money, and health is always at a disadvantage. Now, as per the Abuja Declaration, it was clear that every economy should be able to vote about 15% of their GDP into health. But you know that does not happen. A lot of countries are not able to vote that. So there's always poor investment in health. And the minister will come with that argument. So you need to be ready for that. And then they would also argue, okay, who cares about kidney disease? We have other things to worry about. There's malaria, there's TB, there's HIV. Why should we worry about, chronic kidney disease? You need to prepare for that argument and be able to let them know that chronic kidney disease is so important in the sense that the numbers are growing up. If we don't focus, It will be the fifth most common cause of death. And that's the preamble that we started off with. So we should be clear in our mind the things that we need to be doing or saying to the minister to change their mind, to not only think about the communicable diseases, but to also think about what? The non-communicable disease. And then again, let them understand. They'll say, when people get kidney disease, they are going to die anyway. Why should I vote money into it? And indeed, that is a strong point that we shouldn't wait for them to get a chronic kidney disease. We should screen them early to prevent them from the chronic kidney disease in the first place. Now, making kidney disease a priority is a goal. Now, unfortunately, chronic kidney disease is a neglected, I call it, non-communicable disease, but it has very poor outcomes. Unfortunately, the general population knows so less about it, and that is why we need to rally them along. I mentioned from the beginning, you need some constituents to work with, and that is what I meant by you rallying the population along. Kidney disease is not a death sentence, but most people think it is, and they are not ready to vote money into it. But we need to let them understand that when people are picked early, they can live their full set of life when the appropriate things are done. And we need to intensify the education in terms of advocacy to make kidney disease a priority. World Kidney Day is great. It's one day in a year. In my opinion, it's not enough. For us in Ghana, we take the whole month and we even think it's not enough. So we need to keep drumming home the point of making kidney disease a priority by talking about it all year round. Social media, celebrities with lived experiences, I think, are powerful tools. Identify one and use them, and trust me, you'll be glad you did. Let them know about successful prevention programs, all right, or successful models that have worked in other places. So the Finland Diabetes Prevention Program, for instance, was a powerful tool that was able to reduce CKD progression by 25% by what? Public education and screening alone. And you need to let them know that it has worked in some places, so it can work in your country also. 2, the U.S. Kidney Early Evaluation Program, the KEEP, is also a powerful tool that has been shown to reduce or pick up about 35% of patients early with early intervention. So these are not things that we just talk about. Other people have done it, and it has worked perfectly for them. And I believe it would work in your country also. But you use what you've been using again as a powerful tool. That listen, we used to worry about malaria. There's malaria prevention program. There's TB prevention program. So we also think that there should be a CKD prevention program to be able to, push the agenda. And then I believe that where there is a will, definitely there has to be a way. So an image like this shows that this flower can still grow on the street, provided there's a crack. So whatever crack there is that you can find in the system, use it to your advantage to push the kidney disease agenda. Now, get started, however it is, wherever you can start from. So I'm just showing you some of the ideas that we have worked with in Ghana, for instance. So work with NGOs, so Kidney Health International, for instance, a local NGO that takes advantage of World Health Day. So this is actually an image of World Diabetes Day. Now, we all know the majority of patients the world over with kidney disease are from diabetes. So when Diabetes Day, we go out there. When Hypertension Day, we go out there. We try to screen as much as possible because people will get to know about it, and then kidney disease becomes a household name that people will be able to rally along with. And we actually wrote a paper that Kidney Health International Report was happy to publish. So find it and read it to get some ideas on how we did it in Ghana, for instance, where we said that kidney health for all, effort in a low income setting to enhance community engagement. Community engagement is so important. Kidney health awareness is a must for all of us. Screening is a must for all of us. So start from somewhere. Even if your minister is delaying with little resources, you can start to drum home the point. And that is a way to rally people behind you. Now, generate whatever data that you have generated. Also try and put it in perspective. So like I mentioned earlier, 50 years of dialysis in Ghana, we decided to put a paper in perspective. What we're looking at the current status, the utilization, and the cost of dialysis services. And that data I shared with you, that we got to know that only 8% of our patients who actually require dialysis are getting it. And what are some of the things that we picked from that paper? 1, there's inequitable distribution of dialysis in the country. We had a previous data in 2018 that actually showed that, okay, there was inequitable distribution. And indeed, some 4 years down the line, it was still the same. Now, and this is where we got our 8% of 8% from, where about 15,000 people were expected to be on dialysis. Unfortunately, it's only 8% who were actually on dialysis. And the cost of dialysis, as per our data, was comparable to the monthly minimum wage. So what the minimum wage for a whole month will only pay for one session of dialysis. And again, that is why the majority of patients cannot afford it. And then countries with comparable GDPs like Kenya, Tanzania, and so on and so forth, we're looking at them because they were able to at least take care of twice a week dialysis. So we're like, why not us also here in Ghana? And the direct cost of dialysis was about $8,000 per year. So we tried to make a case for our politicians that, listen, we can also do it. And that is, this paper actually made a lot of gains from the fact that we generated perspective that was useful for our population. And from that time, there was a lot of public discussion. So you can see me on one of our joint news, drumming home the point that, listen, we can do it, because dialysis became a crisis because the government was thinking about increasing the cost of dialysis. And indeed, it was such a good one for public health discussion on how we can actually, reduce rather the cost of dialysis. So the public discussion on health was all over the place. The public weighing into it. And indeed, I can tell you, the public getting into it can change the government decisions, and the ministers will listen to you. And it's always a great opportunity when you get the public, you get social media, you get the media to talk about it, that indeed they can push the government into investing into prevention. So indeed, the image you have on the right is two gentlemen who had kidney disease. So I was online because I couldn't go into the studio. And then we had this conversation, again, using patients who can speak to the subject because they are living the experiences and governments listen to the patients. All right, so I can say that our advocacy has made some progress here in Ghana. Why do I say that? Because all of a sudden, kidney disease was not discussed. I remember somewhere in 2016 when we're going into the election, where I was making noise that if there will be a political party that would have a clear provision for patients for dialysis, just maybe I would vote for them. I could not hear anybody. But guess what? Now, some 5 years or 6 years down the line, our advocacy making some progress. And what are we seeing? All of a sudden, the government decided to roll out free dialysis program for people less than 18 and greater than 60. For us, we got excited because it was the beginning of a discussion that had gone now into the heart of the minister for them to now think about paying for dialysis here in Ghana. Until then, it was not the case. Then all of a sudden, it became a political language. So the one particular party said that, listen, now free dialysis for everybody come from December. And I must confess, from July 2024, government has been paying for dialysis here in Ghana. And in December, they decided to pay for all patients. So as you can see, it was a political platform. They said that they were now rolling out dialysis for all patients who are on NHIS. Then, of course, the opposition did not keep quiet. So the opposition was also of the opinion that they are going to establish modern dialysis centers in all regions that did not have them. And a lot of it was from the data from the publication that we shared, 50 years of dialysis in Ghana. And that is how you can move your people. I am happy to say that always align your ask to the political priorities. So sustainable development goals are talking about prevention of, and helping with universal health coverage, good health and well-being. And then you can slip kidney disease in there. And always look at their political wins also. Sell to them what their legacy will be, that, oh, you are the government that brought prevention for the first time. We can name it whatever it is. And I'm happy to say the new government has something they call the Mahama Care, which has been named according to the president, where they are looking at non-communicable disease, what they can do for our people. So again, what are the political wins? What is the legacy they are leaving as a minister or as a government? And then leverage on existing programs. So if already there's a HIV program, there's a diabetes program, there's a hypertension program, there's TB program, you can go like, okay, can I run with this and come and do dipstick in this area and so on and so forth. Of course, maybe you can get the minister to say, okay, I can buy dipsticks for you and all of that. then you are buying into their priorities one way or the other. I am happy to say that last year we were able to come up with a protocol. So now they called us kidney disease, fraternity. Come, put down a protocol for us in terms of prevention of and management of kidney disease. So when people in the district are able to pick it, they are able to prevent what? The progression. And we are happy to say that the protocol is there, it's been drawn, and we are hoping the minister can sign. So indeed, we have actually started training with the protocol even already. And yours truly was part of this. And we are happy that the ministers are listening to us. What are the key pillars to target as I bring my presentation to a close? The economic rationale I have mentioned. Prevention always will reduce the long-term health expenditure. Let them understand from the economic point of view. The moral obligation. If we prevent people from getting kidney disease, they don't suffer. And the vulnerable are the ones who cannot afford at all, and they don't suffer. And you can always, I am an equity expert too, I always want to bring out the equity bit of it also. So moral obligation is always very important. You don't want the suffering, the people to suffer, because when we prevent it, of course, then they don't suffer too much with kidney disease because we are picking them early. Political advantage, of course, your politicians will always be politicians. So drum home the fact that they are leading a visionary leadership as they are bringing reforms into that particular area, as you make that point into to them. And again, like I said, the equity bit, early detection, interventions will be, so it's like, oh, sometimes people are making a case that we are all paying premium, where we are not getting anything out of it. If you roll out a prevention program, everybody tends to benefit. So they don't feel that they are wasting their money into the program. So that is also very important. So in summary, what have I said so far in the last 40 or so minutes? Get good quality data. Simple data from hospital is useful, but nonetheless, you can push to get good quality data that will be able to drum home a point. Write on existing structures and programs. If you have any program that is existing, don't begin a new thing altogether. It might be more difficult. Run with the existing program and it becomes a bit easier. Take advantage of the media houses, social media, celebrities, whatever you have, work with it, because trust me, it goes a long way to drum home the point. Have a strong local nephrology society. Come together as a nephrology society, and as you meet, invite ministers, and don't just invite them, give them t-shirts. Make sure that you follow up with programs that will be able to be sustainable. Write on strong patient advocacy groups, NGOs and celebrities and whatever it is, like, because trust me, when they hit the airways, all the airways, like I said, are talking about kidney disease, the government wouldn't have a choice. They would listen. Invite politicians to World Kidney Day activities, and like I said, don't let it end there. Always ensure that you are always getting them involved in programs. Throw something at them to work with as a legacy for them, and show them that kidney disease is not a death sentence. It is something that we can always do something about to improve the lot of our people. Investing in chronic kidney disease prevention is an investment in our people's health and in our nation's future. And this is what they need to understand. Rally people along and make sure that you get the needed support as you need it, and not alone. Thank you very much, and I'll be happy to take your questions if there are any. And again, contributions as to what has also worked with other people. Thank you very much. Maza, over to you.
Thank you so much, Elliot. As always, a fantastic presentation, very passionate and amazing, amazing, amazing work that you have done in Ghana. And I believe most of us, would like to follow suit. And I think this is like a framework that you have put out for us, and we can pick and choose what we can take and work from that way onwards, hopefully achieving, what we would like to achieve, and try and reduce, at least not halt, but reduce the epidemic that is getting to us. Maybe just before we take questions, perspective from Tanzania is that we are seeing more and more people coming on, to dialysis, and people are crash landing on us every now and then. Things are getting saturated. Very soon we will not be able to provide dialysis services because of the burden of patients. And then obviously, those patients, I mean, in Tanzania, there's two ways that you can get dialysis. One is that if you're insured, and second, if you can pay cash. And not many people are insured, right? So majority of the patients have to pay cash. And as catastrophic as it is financially, not many cash patients can continue with paying, even though the cost, is relatively, not that high. But still, it is something that is many people cannot afford. People have to sell their houses, they have to sell their land to try and make ends meet and get one dialysis session a week, which, in clinical terms is not adequate at all. So, as the idiom goes, prevention is better than cure. This is exactly what we mean, that we need to intervene sooner, earlier, and make sure that we reduce the number of patients that are coming onto dialysis. So thank you again for that presentation. We have a few questions. Do you like me to read them through, or would you want to go through the Q&A and answer them accordingly?
Okay, you can coordinate it, but I'll also be looking through them.
Sure, no problem. So, Prof. Joraya has commented that excellent presentation as usual. He follows up with a question. To convince health authority is to consider costs. So how to make renal disease treatment cheaper in SSA, since dialysis session costs 4 times more in sub-Saharan Africa than North Africa?
Yeah, so exactly the point. I mean, we had a minister meeting, I think somewhere last week or last 2 weeks with the minister, where indeed, yes, they are ready to support, but they are like, listen, how can we make it cheaper? And the answer is simple. I mean, if we can produce most of these consumables locally, it becomes easy. Unfortunately for us, most of our consumables are imported and they are slapped with taxes, the import duties, and of course, our currencies here also in sub-Saharan Africa are not, that strong. And if indeed you are importing, from, and you need to convert to dollars, then chances are that the dollar rate affects the amount. So technically speaking, you run yourself, it's like a rat race of some sort where we are never winning. But can we set up industries and produce some of these consumables at least? I mean, in our part of the world, if we can produce them, then it becomes a bit cheaper. And then, of course, what the government, again, the next point we made to them is that if the government is importing en bloc, then it might be cheaper. Now, the dialysis industry is a cartel, and I believe it's like that everywhere. Only few people in that industry, they sit in one meeting and they decide, listen, this is how much we are charging them. There's nothing you can do. But if the government gets involved and is importing these things as a whole, chances are that they can get it cheaper from, let's say, India, for instance, or cheaper from China. And then the cost will come down. But if we are to leave it to individuals and hospitals to keep importing, then it might be a problem. So I think, Prof, that is probably my suggestion for how we can look at cutting down the cost, because it's actually very unbearable that it's more expensive here in Ghana, expensive in Africa than, other parts of the world. And it's all because of some of these challenges. Thank you, Prof.
Thanks, Elliot. The next question is from Nancy. She is a family physician here in Tanzania, but she's also part of the Aga Khan University in East Africa. She says, given the lack of robust kidney surveillance data, how can family physicians contribute to national registries or data collection system to inform policy and resource allocation?
Thank you very much, Nancy. But you have a major role to play here so far as, collecting data is concerned. I mean, I mentioned the African registry, for instance, with which our mentor, myself and Maza, Prof. Davis, happen to be championing. And we need to all get involved. One of the challenges is that when you have dialysis centers that are scattered all over the country, you ask them to bring data, they don't bring the data. So it starts off, Nancy, with you at least setting up a little, I mean, it might be a book, it might be your electronic, medical records, where diagnoses are clearly made, and have a way to, rally or put it together as a country or whatever it is like. But the Share RR, which is the ISN, Share RR group, actually has a toolkit that directs countries as to how you can set up your own registry. And I think Prof. David is actually a key kingpin in this Share RR thing, which I would suggest that we all get onto the ISN website, get to know how it is done. And it's virtually not too difficult, very simple data that we now have to be very intentional to always input to be able to get that surveillance running. Because to be honest, without the data, your minister will look at you and then, sack you, because they are collecting malaria data every day. They are collecting TB data every day, HIV data every day. But the systems that have been put in place doesn't think so much about non-communicable diseases. So we find ourselves, shortchanged, that when we are supposed to even go onto our own DIM system or LIMS system or whatever system that we have, there's no CKD data there. So the minister sitting there goes like, oh, CKD is not a problem because it's only 1% or 2% or, but meanwhile, it's a problem because one, we are not screening for starters to even pick them. Two, we are not entering the little that we are screening. So Nancy, we all have a part to play in building these registries, or else there's nothing to write home about. Thank you very much, Nancy.
Thank you, Elliot. Prof. Jaraya continues to say that and medications are copies and are frequently found in pharmacy and street markets in sub-Saharan Africa. So prevention is not effective. I'm not sure what Prof was trying to say, but maybe if you can answer that.
Medication copies are frequently up. So yes, I think the medication issue, I agree on that part. Prevention, yes, can be effective depending on how we look at it. I mean, now when we talk about prevention in any case, from where we come from, Prof, I mean, your average patient who has diabetes, hypertension, like Mazar mentioned, will come to you when it's late. And you ask yourself from the beginning, who was attending to this patient that he knows so well this patient has been diabetic for 10 years or 5 years, and not even a dipstick has been done, or a renal function test has never been done. And the first time they noted that urine, there's facial puffiness or there's pedal swelling, they now say, oh, okay, let me go and check the renal function, and boom, the creatinine is over 1,000. And they say, okay, now go and see the nephrologist. By the time they come to Maza, it's so late. The prevention bit is picking risk factors and making sure that we are picking them up early. So I think prevention can definitely be effective if we are looking out for these risk factors and we are actually picking them up early in terms of early detection. In my opinion, even just simple advice, I mean, to your patient, avoid painkillers, avoid herbal medication, drink a lot of water, ensure you are taking your ACE inhibitors, ensure you are taking your, they will go a long way. So that will make the prevention effective. Otherwise, then it might not be effective if we are just waiting for them to come late.
All right, thank you. We've got a follow-up question from Nancy again. Family physicians as a group with wide patient access, how can they be supported to advocate CKD screening, prevention, funding, and inclusion in essential health service packages, especially for those covered under National Health Insurance Fund?
Yeah. So how can we? Definitely you can. I think so. I don't joke with family physicians at all because, to be honest, I keep saying before we see them, you have been seeing them for like forever. And what you know is very important. The protocol that I mentioned that we have put together, the focus of the protocol is people seeing our patients at the primary and secondary levels, even before we see them at the tertiary level. And family physicians are such a major role player in this wise. So what I'm saying is that if you have a diabetic, if you have anybody, in my opinion, about 40 years, if you have a hypertensive, you have somebody with a heart disease, you have somebody with a liver disease, you have somebody who tells you I've been taking painkillers for, I don't know, my back pain or my knee pain or herbal medication. These are the people you need to screen. Now, let's not make excuses for them that they don't have money to screen. Trust me, if it will cost them X amount of money, it will cost them 10 times, 100 times when they come on dialysis. So let them save some money to get themselves screened for urine dipstick or urine UACR or UPCR, whatever you have, get them screened, get them checking their blood pressures, get them checking their sugars, get them checking their renal function. To be honest, if you pick them up early, there's a lot you can do to ensure that they don't get there where we don't need them. Because indeed, sometimes when you pick them, you're diabetic, you can even encourage the person to get registered on insurance before they get into end-stage kidney disease. So by the time they need a dialysis, they're on insurance, then chances are that, in Kenya or Tanzania, maybe then the insurance can take care of them. But like we said, if they come so late and they're already not in insurance, then it becomes very difficult. Yeah, thank you very much, Nancy. I love your questions. Yeah.
Thank you, Elliot. I think you probably answered the follow-up question. Family physicians are often the first point of contact in the healthcare system. What strategies can be employed to better equip them in early detection and risk stratification of CKD at primary care level? What has worked in your country in this regard?
Yeah. So
So I
I think,
believe
like
you've
you said, it's
partially
been
answered it.
largely
Yeah.
answered. Yeah. So
Yeah.
what has
Yeah.
worked is we would always organize CPDs like this or programs like this, and we will invite all of them and we'll take them through basic training, simplify the message. You know, your average physician out there is afraid to even look at the renal function or the creatinine because they think that there's very little they can do. So we try to demystify, you know, renal function, UACR, dipstick, and all, so that they can be a bit more welcoming to encourage their patients to do it. But I think the large part of the question has been answered. Yeah.
Thanks, Elliot. We've got another question from Dr. Huda Akrabi. She's a nephrologist from the foothills of Kilimanjaro. She says, in what ways can we involve the private sector and other stakeholders to support CKD prevention initiatives?
Thank you very much. I mean, private sector is always interested in the win-win. What is in for us? What is in for them is the fact that when we screen patients, and indeed they can even lead the screening exercise, it's patient to their hospitals, right? So I keep saying that sometimes when I come and drum home, let's screen, they end up making more money than those who end up being referred to me, because the point is that if you screen 100 people, at least it's probably not for free. Chances are that they might pay something small. Or even if you do a free screening in terms of dipstick and you pick a positive and you say, okay, follow up and do a renal function test, it is money for you. So yes, you can largely be involved. If you decide to even, you know, sponsor a World Kidney Day or sponsor a World Diabetes, World Hypertension Day, and you vote some little money, those that are screened, private sector, chances are that they will be referred to your facility. And if they come for even 3 clinics per month or 3 clinics per year or 1 clinic per month, that is revenue for you, my private sector. So it is a win-win, however you look at it. So I think that get involved, and chances are that you will not be sad that you did. You rather be happy because you'll be making more money, basically.
Right. So just a fun fact, Huda trained in South Africa. She trained in Cape Town as well. She is working
Great.
currently at the Kilimanjaro Christian Medical Center, which is a governmental organization in Moshi, the foothills of Kilimanjaro.
Yeah.
Okay, we have Dr. Buguyu, who is the Assistant Director of the Non-Communicable Diseases Program for Tanzania. I'm not sure if Dr. Buguyu, do you want to unmute and perhaps ask your question, or would you like me to just read the question? It'd be great to hear from you. Can you unmute and
maybe he
speak?
wants you to read out, then I can answer.
Okay, all right, fine. Okay, so he's saying that he just wants to know if there is any algorithm on the management of chronic kidney disease based on comprehensive data obtained from Africa, which put in consideration both biological and socioeconomic factors that can be used in modeling and predicting the outcome of dialysis services, as well as assist in developing investment case for both dialysis and transplant services.
Okay, so I think he's come. I think he can now unmute and speak. I realize he tried to unmute.
Yeah, you can. Yeah, you can unmute, Dr. Buguyu.
Thank you. Okay, thank you very much, presenter. And the presentation was very insightful. I'm a psychiatrist by profession, so this niche is very new to me. But I'm supervising the renal services in Tanzania as well as part of the NCD. And we've been struggling with the dialysis and transplant. And it has been unbearable to most of the Africans based on number of sessions that one has been prescribed. And many people, first of all, got the disease, ran bankrupt, and then they died, which is in a social economic perspective, in psychological and well-being, it is not fair. So I was just wondering if there's any comprehensive data that we have, and we have our own model of doing transplants. I mean, dialysis and transplant services, if there's any comprehensive data. So you presented well my question. Just
Thank
to hear.
Yeah, thank you very much, Doc. So fantastic, fantastic questions. Yeah. So the objective here probably would not be model into risk of dialysis, all right? So as much as possible, the focus of this discussion is to make sure we don't get there in the first place. But of course, because you have asked, I'll probably mention that nowadays we have, in fact, as per the current KDIGO guidelines 2024, it is clear that now we need to be looking at determining people's risk of requiring renal replacement therapy, all right? So now there's a clear algorithm where all you need is, in fact, slot in your patient's name, the age, the gender, a few other parameters, and it will be able to clearly determine the risk of progression, in terms of percentages to kidney failure and all. So I think it is something that I think we should use. And it's an online risk assessment tool, which we can all use. I mean, whether or not, wherever you are, and depending on whether you are seeing the patient with CKD, with other parameters, their bicarbonate and all of that, it adds, okay, even to the sensitivity of that particular marker. So maybe if there's a day we are talking more on, dialysis and all, I'll probably delve more into it. But I think the essence of the discussion here is as much as possible to ensure that we don't get there in the first place. Now, the key thing is that, which you actually mentioned, the biological and the socioeconomic factors are against us. Together with a group of colleagues, we actually wrote a paper where we were looking at the socioeconomic impact. And I think that in our part of the world, we suffer so many things just because of the socioeconomics, right? People are not even getting to the hospital in the first place because they don't have money. They will try and do the herbal medication because they don't have money. They are not able to follow through their medications because they don't have money. They'll go and do the other unorthodox medicines because they don't have money. And fundamentally, they are even getting CKD early because they didn't have money. They were getting diarrheas in children and all. So find time, I actually structure the risk of CKD right from our mother's wombs. Our parents are pregnant with us. They don't even know they are pregnant with us. They are not going to the hospital early. They are getting the preeclampsias. They are not taking their blood pressure medication. We are born with low birth weight or born premature. We are getting diarrheas and all of that in childhood, So before your average Southern African child gets to age 40, the kidney would have received so many knocks. And fundamentally, because we don't have money. You get it? So that by itself is such a major problem. And that is why we feel that our risk of kidney disease age should not be 60 years, like most of our books are telling us. It should be lower than that. By 30, 40 years, we should be screening everybody across board because of all of these risk factors, right? So I think that is how I'll try to answer the question for now. And in terms of the modeling and the predicting tools for, like I said, the dialysis services, we'll look at it from, the tool that I mentioned, which is an online tool, but it might become necessary for us to develop our own tool. I think that is another angle you were coming from. I think the more data we get, the more it is that we can develop our own tools. And I have a feeling whatever tools we are using now, because of these socioeconomic conditions, we may have to tighten up a bit based on our own parameters. APO1 is here with us, and a few sickle cell is with us. We have other unique things that are unique to us, which we may have to factor in these models. Thank you.
Thanks, Elliot. Maybe we can take the last couple of questions. It's already 8 p.m. on this side. So one question from an anonymous attendee is, does frequent use of pediatric painkillers also put children at risk of getting chronic kidney disease?
Yeah, painkillers is painkillers, and more especially the NSAIDs are always a problem to the child, to the adult, to the old person, wherever you find it, just because of the mechanism by which these painkillers work. And if you take them, sometimes once could be a problem for you, sometimes over a period of time, even worse. But nonetheless, the key thing is that if you desperately need these painkillers, ensure that your patient is hydrating well. Because the effects of these painkillers, when they are hydrating well, might reduce. But nonetheless, look for the cause of whatever it is, try to treat it appropriately so we don't put patients on painkillers for so long when they don't need them. I think that is how best I would answer them. But let's stay away from painkillers. It causes an acute kidney injury in itself and definitely chronic kidney disease even in the long run.
Yeah. Thanks, Elliot. The last question comes from Dr. Suda. She's a nephrologist here in Dar es Salaam. I believe you know her and met her in a few of the conferences. What is stand of or if any focus programs under ISN and AFRAN on this agenda, and how can we collaborate as a country with them?
Yeah, so thank you very much. Suda, my greetings to you and good evening. All right, so fantastic question. All right, yes, we need, I mean, and I think Suda, you know so well. I mean, anytime I have a platform on ISN, we try to make noise that, listen, we are unique and we need to have clear programs that are targeted at us, because chances are that they might not understand our story and what kind of troubles that we go through. So we clearly need focus programs here in AFRAN, and I think that is why AFRAN is here, because we need to let ISN know what our challenges are. So you and I, as young nephrologists or growing up nephrologists, should now come up with what we think is best. And I think ISN now, AFRAN now is very vibrant. I mean, we have people like you, people like Maza now pushing the frontiers of AFRAN. And now our voice is heard, and we are penetrating in ISN. And chances are that we need to come up with whatever we think is good for us, as a program. Clearly, we can make all the noise that we want, but if we don't collaborate, we don't win. I can sit in Ghana and make noise. You can sit in Tanzania, but the moment we are together, we have a stronger force, and sooner than later, we'll be getting a black ISN president, one way or the other, to be able to channel or push our agenda the best we can. So it is very important that we collaborate, and that is why we are having conversations like this. Thank you so much.
Thank you so much, Elliot. Thank you, Suda, Nancy, Prof. Jaraya, and Dr. Buguyu, and all the rest for your questions. I believe this was a very insightful presentation, and I think we cannot get enough of this. It is something that I feel is a two-way sword. Yes, we have to make sure that we continue propagating prevention and screening, but I think it's also important for us as the medical fraternity to educate ourselves on the same, to be able to propagate this. So I think this is something that the local societies should take up as one of their key messages that they want to come across as a key performance indicator, if you want to call it, and say, okay, in this 1 year, this is what we would like to do, X, Y, and Z. So I think this is very, very important. So I would like to thank you very much on behalf of the Clinical Nephrology Committee, Elliot, for your absolutely fantastic presentation. And as expected, there was quite a bit of engagement on this. And please, if possible, do share your slides. We will also share the recording on various groups for those who were not able to attend. And for those who will require these slides, we can also share it with them. Thank you very much. And I wish you a good evening, and hopefully we can have another chat sometime later this year on the same platform. Thank you so much.
All right, sure. Thank you so much, Maza. And one fantastic moderation by yourself also. And I probably need to say this. Maza found my accommodation for me when I came to South Africa. It's by Maza that I got a place to stay when I got to Cape Town the first time. Thanks, Maza.
It has always been a pleasure, and it was always nice to have met you. And I believe that this is something that we will take together in the future as well. Thank you so much.
Sure. Thank you so much.
Take care.
Okay.
Take care.
Okay.
All right. Thanks.
Bye-bye.
Thanks. Bye. Good evening. Thank you, everyone.